आसपास गए हैं ना, प्रॉब्लम हो गया?
हाँ नहीं कुछ नहीं होगा, मैं यही इधर ही हूँ।
हाँ, ये सिस्टम मैंने कभी हैंडल किया
नहीं कोई प्रॉब्लम, मैं इधर ही हूँ।
मुझे कुछ नहीं करना, सिर्फ आगे आगे
बस आपको तो अपना ये स्लाइड नेक्स्ट प्रीवियस ये दो है बस,
और कुछ नहीं करना।
और माउस का जरूरत पड़ेगा तो वो पॉइंटर का जरूरत पड़ेगा तो माउस को यूज कर ले। ठीक है सर, स्टार्ट करो। बस आपको स्लाइड वो करना है,
पॉइंटर करना होगा ना,
सब कर दो
जैसे ही करना।
हाँ
अच्छा, इसमें पॉइंटर होता है, इसमें पॉइंटर ऑप्शंस,
तो माउस को हिला के करते रहेंगे, उससे भी आ जाएगा।
अच्छा, और क्वेश्चंस कैसा होगा? लोग क्वेश्चन कैसे पूछेंगे?
जैसे आप अपना लेक्चर रन करेंगे ना,
हाँ।
ईमेल आईडी दे देना, इनको बोल देना कोई क्वेश्चन पूछना आपको तो ये मेरा ईमेल आईडी है।
अच्छा, वैसे बीच में नहीं बोल सकते?
उधर आपका वीडियो ऑडियो जा रहा है, उनका कुछ नहीं आ रहा है।
कुछ नहीं आ रहा? अच्छा, जूम जैसा नहीं है,
वो वाला सिस्टम,
वो वाला नहीं है। ओहो,
मतलब आप जा रहे हैं उधर।
अच्छा, तो उसका कुछ डिफिकल्टी है?
आपकी स्लाइड जा रही है, ऑडियो वीडियो जा रहा है।
अच्छा, तो वो लोग कुछ भी नहीं पूछ पाएंगे? कोई चैट का कोई ऑप्शन भी नहीं है?
वो अपना ईमेल आईडी दे देंगे ना, वो बच्चे जिसको
ओहो, तो मैं ईमेल आईडी का एक स्लाइड बना लेता हूँ मैं।
या अपना फ़ोन नंबर बता देना, तो मेरे पास कोई मैसेज।
क्या चीज़?
फ़ोन नंबर भी।
तो फ़ोन नंबर तो मैं दूंगा फ़ोन नंबर तो मैं देता नहीं है किसी को। ईमेल आईडी या ईमेल आईडी बोलना पड़ेगा। और इसको खोल के बोलना है, इसको निकाल के बोलना है?
लेकिन अपने को इंट्रोड्यूस करके फिर लगा लो।
अच्छा, और तो होगा नहीं कमरे में वैसे
तो मैडम नहीं है, अगर आई
तो उसमें एक बार फोन
मैडम कर ले।
अब ये दिख रहा है क्या उनको? दिख रहा है? इस पे नहीं आएगा ना? अच्छा अब देख लीजिए मेरी बोरिंग पे है ना वैसे। Good afternoon and welcome you all to this talk on the drugs in patients of organ transplant. You are now, I think, in the 5th semester. You've been introduced to the pharmacological aspects and also started going to the wards for ward patient care. So I'll try to give you an overview of how these drugs are used in actual patients. So the clinical correlates I'll try to give. I will go slow because I think interaction is not possible. Yeah, so interaction is not possible. So I'll go slow, and if you have any queries, etc., maybe you can email them to me subsequently. Right? Yeah. So you can email them to me, and I will respond subsequently. I think Professor Pooja Gupta has already covered the basics of the basic pharmacology of these drugs. There will be some repetition, but I think that would be useful. So the learning objectives in today's class is to understand the clinical usage of various drugs in the recipients of solid organ transplant. Okay, we will be covering only the solid organ transplantation. Now that is the basic, the crux of today's talk. Apart from that, you should also learn how to counsel the patients appropriately regarding these transplant patients, their vaccination needs, if they're planning pregnancy, how you will handle their other ailments, because these transplant patients will in due course have other issues as well. And then if you are not a transplant related physician or a surgeon, as a general physician or as an internist, you might come across the prescriptions given by the treating doctor. So you should understand, know how to interpret the prescriptions of the patients. So I'll give you some actual prescriptions so you see how it looks like, so you'll have a feel of it. So now let's start. So we'll cover this lecture under this following headings: the history of transplantation, various regimens. So you may have been told about the individual drugs, but then all these drugs are used as a regimen. They're all used in combination. They're not used singly. We talk about induction agents. So induction agents are the drugs given prior to or at the beginning of transplant and not given subsequently, and they're not used for treating rejection. Then how to treat rejection? Drugs used for prophylaxis of various infections to which these patients are prone. We talk a little bit about pregnancy, vaccines. We talk about the other antihypertensives, antidiabetics, anti-ulcer drugs, calcium supplements, etc., which these patients invariably receive apart from the immunosuppressive regimens. And then, as I said, we will review a few actual prescriptions of the patients. Now, coming to the types of transplantation, you have the autograft or the syngenetic or the isograft, where the graft is genetically identical to the recipient. Okay, so auto means the same person, like we have auto-renal transplant. So suppose it's renal artery stenosis, you take out the kidney from its native original position and then graft it in the internal iliac fossa. Okay, so it's the same graft from the original position to a new position to bypass an obstruction. So that is an autograft. Then you have a syngenetic or isograft between twins, you can do it. So that is genetic related. So here obviously you don't need any immunosuppressive agent. Then you have allograft, where the transplantation is done between different members of the same species, and that's what basically we're going to talk about today, right? So it is human to human solid organ transplantation. And then you have xenograft, which is still in an experimental stage, where you transplant across the species barrier. So that is still to come into clinical practice. Now, leaving the genetic aspects apart, the other classification is a hematopoietic stem cell transplant and solid organ transplant. So that is basically the bone marrow transplant in common parlance. So we will be talking today about the solid organ transplant. So what we're talking today is about the allograft and a solid organ transplant. And solid organ also basically, because I am a nephrologist, we'll basically be talking about kidney transplantation. The drugs are almost the same in liver transplant and other solid organs. So if you go back to the history, experimental transplantation started way back in 1902, and then they found that these allogenic tissues were rejected, and so it did not take off. In 1948, steroids first came into use for rheumatoid arthritis, and then people knew that it probably suppresses immunity. And in 1954, as you're all aware, in Boston the first kidney transplantation was done between identical twins, and they didn't require any immunosuppression. Irradiation came in 1950s. 6-mercaptopurine as an immunosuppressive was introduced in 59, and its derivative as a thiopurine came in 60, and this became a wonderful drug for treating renal transplant along with steroids. In 1962, one understood the use of tissue matching for donor selection, and then this combination was started. The real revolution in renal transplant took place in 1980 when cyclosporine was introduced. So before that it was only steroid and ASA. I myself have seen transplants as a resident with only steroids and ASA. Cyclosporine came into India in the late 80s. Okay, that's when I just started my renal transplant program. And in 1990, tacrolimus was introduced, which was another revolution. In 2000 came sirolimus and mycophenolate mofetil. And mycophenolate mofetil has now become the backbone along with the tacrolimus and steroids. We'll talk about that subsequently. And sirolimus is used not too much in about 10-15% of patients. After that, as you see now it's another 20 years. No great advance took place till about 2010 when another drug came, and I will talk about it in my last slides. So when we are giving immunosuppression, why we are worried is because basically we are trying to balance rejection versus infection. Rejection because this is a graft which has a different genetic makeup, and the body rejects an outsider. And if you give too much of immunosuppressives, then the patient is prone to infection, malignancy, diabetes, and many other complications. So that's why there is a skill required in trying to balance these two issues. I think madam has already covered most of these things. We'll quickly go through it. So steroids is the backbone. It's given as prednisolone as a single morning dose after breakfast. Initially it was given as a high dose, tapered to 10, but nowadays we start only at 20, and we rapidly taper to 5 or 7.5 milligrams. Different institutions have different protocols. We normally by 3 months come down to 5, 7.5. There's a lot of side effects in pharmacology. You're reading all about it. We will not go through it, and that's why now there is a trend towards using steroid-free or steroid-sparing regimens. So where you try either not to use steroids at all, or you stop it after 1 week, or you use it in a minimum dose. So these are various protocols used by various institutions. Azathioprine is a purine antagonist. It is again given as a single daily dose, 2 to 2.5 milligram per kilo. This is usually given at night. I'm not sure why, but that's how we have been taught. Its major side effect includes leukopenia, so you have to monitor TLC. Occasionally you can have hepatotoxicity and alopecia, but the major issue is leukopenia. And it is metabolized with xanthine oxidase. And that is important to remember, because if you give it in combination in a patient with gout with allopurinol, then it will reduce by 75%. Otherwise, you get very high levels of azathioprine and then the counts drop drastically. So that's, you have to be very careful if you are combining allopurinol with azathioprine. It is quite a cheap drug now, but what has happened is, I told you in 2000 mycophenolate was introduced, and in the last 10 years now mycophenolate mofetil has almost replaced azathioprine except in a few cases. So this drug, which was a basic drug, is now very rarely used in transplant. This drug MMF is a fermentation product of fungi. It inhibits guanine synthesis. It is better immunosuppressive than azathioprine. It also causes leukopenia. The other side effects being diarrhea, which is not uncommon. There could be gastrointestinal symptoms, and worse, it increases the chances of infection by various viruses. So one has to be very careful, especially the cytomegalovirus. And malignancies may be more, but that is not definite. MMF comes as a 500 mg formulation, and the dosage is 2 to 3 grams per day in 2 divided doses. Now in the Indian population, normally we do not exceed 2 grams per day, that is 1 gram BD, that is the standard dose. Very occasionally the patient is heavyweight, then we may go up to 3 grams, but definitely not more than that. As I told you, it causes diarrhea, and so then they came up with an enteric coated sodium formulation where 360 mg is equivalent to 500 mg. Again given as a BD dose, so you give that as maybe 720 mg BD. Not sure if it has really helped in reducing diarrhea or not, but then one can try substituting MMF with the enteric coated formulation if the patient has diarrhea. Now when you give it in combination with tacrolimus, which we'll come to later on, you can lower the doses of MMF. So you can even go down below 2 grams per day. Many patients receive only 500 mg BD. And also very importantly, it has no interaction with allopurinol. So you don't have to worry about reducing the dose if the patient has gout and you are giving allopurinol. Now coming to cyclosporin, which, as I said, revolutionized the transplant field. It is a fungal product developed by Novartis. It was developed in the lab in Switzerland in Basel. It's basically a calcineurin inhibitor, so we call it as CNI as a short form. Cyclosporin and tacrolimus are both CNIs, and what they do is basically they inhibit interleukin 2, and that inhibits the generation of CD4 T helper cytotoxic lymphocytes. Okay, don't worry too much about all this, but we'll study all this in medicine later on, that when the CD4 is activated, the generation of the helper cytotoxic lymphocytes, you get IL-2, which starts the rejection. So the CNIs, by inhibiting interleukin 2, will inhibit the rejection. Now the original cyclosporin which we used way back in the late 80s, whole of 90s, and in India till early 2000, was a lipid formulation, which was given in milk or in fruit juice. So this liquid formulation is still available, and that used to have a titration meter, so you could measure out exactly how much to give. Put it into a cup of milk or a glass of milk or fruit juice and take it along with that. In 1995, Novartis came out with a neural microemulsion capsules. So now routinely these are used in children, in kids. Still this liquid formulation is used. It's still available in the market. It's still available. But routinely in adults now we have these neural microemulsion capsules, which we are using since 2000. and they come in fixed strengths of 25 mg, 50 mg and 100 mg, right? So you have to adjust the dose accordingly. And now generics are also available in the market. Cyclosporin is again given as 2 divided doses. Initially, when we started our training, we used to give it as 8 mg per kilo and per day. In Europe, in some centers, they tried a monotherapy. They didn't want to give steroids at all, so they use monotherapy as 15 mg per kilo in 2 divided doses, obviously. But then that wasn't a success, because cyclosporin, although it is given for preventing rejection, unfortunately it itself is a nephrotoxic drug. That is one of the ironies of the situation, that the CNIs, they are themselves nephrotoxic. So giving such a high dose is not really a good idea in any case. So anyway, so this is no longer used. Now the standard is 5 mg per kilo per day, and it is part of the triple therapy: cyclosporin, prednisolone and azathioprine, which I showed you. And the results of renal transplantation improved remarkably. In fact, when cyclosporin was not used, we used to get violent cases of acute rejection. The kidney would become swollen, painful, red, fever, graft dysfunction. All that is no longer seen after cyclosporin was introduced. So transplantation became a much quieter affair after the triple therapy was introduced. It did a good job in reducing acute rejection, but then the chronic rejection, the graft life as such has not really improved even with cyclosporin. So as I said, it reduced irreversible rejections in the first 3 months post-transplant, and the signs of rejection became more subtle. So you have to be more adept at picking up rejection even without fever, pain and redness. As I said, it has many side effects. It causes hypertension, it causes tremors, it causes gingival hyperplasia, it causes hirsutism. So that is not a very good thing, especially it's a child or a female. So so one major drawback with this drug. And the most bad thing about it was that it is nephrotoxic, and it causes nephrotoxicity in all the compartments of the kidney. It constricts the afferent arterioles, and experimentally when you give IV cyclosporin by the way is available as a IV formulation also. And what was done is that when the patient is nil by mouth immediate post-transplant or after or before the surgery peri-op period, we could give it as an IV formulation, and the IV dosage is 1/3 that of the standard dose. So it is still available, so that's an advantage because you can use it. So in experiments it was seen, and these pictures are there in our textbooks even now, that in rats, when you inject a very high dose of cyclosporin intravenous, it immediately constricts the afferent arterioles, and the glomeruli, they almost shrink, because they are not getting blood supply. So when you give chronically a higher dose, it can cause afferent vasoconstriction and reduce the GFR, and that's how it increases the creatinine. It can cause a picture of hemolytic uremic syndrome. I'm not going into detail of that. As the name suggests, it causes hemolysis, it causes thrombocytopenia, and it can increase the urea. So that is the HUS. It can cause drug-induced HUS. And worst is that if you give it for a very long time, then it causes interstitial fibrosis and tubular atrophy, which in our language we commonly call as IFTA. So it causes IFTA of the kidneys. So the kidneys become less functional, and over years when you keep giving cyclosporin for a long time, the GFR reduces and the kidneys may ultimately even fail. And that's why I said cyclosporin, although it reduced acute rejection very well, it did not really improve the graft outcome. Right, so this is about cyclosporin. Because it causes so much toxicity, you have to monitor the drug levels very carefully. The window is very small. So this is done in two ways. One is the C0 level. C0 means 12 hours after taking the drug, before next dose. Because as I said, it is given in BD dosage. So C0 is the least level, and that is achieved just before the next dose. So that is in the morning, say around 8:15, before he takes the morning dose. The other way of monitoring it is through the C2 level. C2 means 2 hours after taking the drug. So that is through the peak concentration, right? Now what is the advantage of which to do, when to do, that is still controversial, but in general in the first year you do the C2 because you want to know that the peak levels are okay, and thereafter you monitor the C0, and the levels are done like this: 500 initially, and then you come down to 100 by 6 months. If you're doing C2, then 1600 initially and come down to 500 by 6 months. It has many drug interactions. The levels are increased when you're giving azoles, ketoconazole and voriconazole and all those antifungals. So if you give that, the levels increase, and that can cause toxicity. Or if you are giving macrolides like azathioprine, which is a very common antibiotic, so then patient can get nephrotoxicity. On the other hand, if you combine with rifampicin, the ATT, then the drug levels drop precipitously. So one has to be very careful if you're giving it along with rifampicin. So many centers do not use rifampicin in the ATT regime when you are using cyclosporine. Then with anticonvulsants like carbamazepine, again the dose is reduced. So in these cases one has to be very careful. Either you preemptively take the necessary action of reducing or increasing the dose, and then of course you have to monitor the level also. Of course, if you're giving these macrolides for a short duration, for 3-4 days for a common cold or something, you don't have to really bother too much. Now, as I said, cyclosporine formed the backbone of all the protocols after it came into use, except the monotherapy, which was given up after a few years. So it was used as cyclosporine plus prednisolone, it was used as cyclosporine plus azathioprine. Then when azathioprine was replaced with mycophenolate, it was cyclosporine plus MMF, then cyclo plus MMF plus PRED, and then the sequential, the quadruple therapy, where you gave these biologicals as an induction. So you gave this induction agent initially, preoperatively, perioperatively, suppressed the patient's immunity, and what you did was combine it with azathioprine and prednisolone. You did not add cyclosporine. Now this is especially relevant in cadaver, the diseased donor transplants. What happens in cadaver transplant is, because the patients are taken from a diseased body, the blood supply has stopped, these kidneys develop some damage, we call it as ATM, acute tubular necrosis. It's something like a stunned kidney. The kidney does not work initially and then picks up the function for the next 3, 4, 5, 7 days. So during that period, you are not giving the CNI, cyclosporine, and the anti-rejection work is taken over by the ATG or OKT3. I'll come to that later. And you give azathioprine prednisolone. So the nephrotoxicity of this drug is reduced, right? So this is called as a sequential therapy. So you give initially this induction agent with aza plus PRED, and then once the kidney started functioning after 7 days, you added cyclosporine. This problem is not so much there in living donor, because there the kidney starts functioning immediately. You see urine on the table. There you don't really need this, right? But this was used very commonly in those countries and in those centers where one practiced diseased donor transplant. Now what has happened is, over time, as I said, in 2000, around 2000, 1995, 2000, the other CNI, tacrolimus, came to the market. Tacrolimus was initially used by the liver transplant people. They are the ones who introduced tacrolimus in clinical practice, not the nephrologists. And they found it very useful. Some nephrologists were very slow in accepting this drug. And we started using the drug almost a decade after they started using. So only in mid 2000 we started using tacrolimus. And now what has happened is it has almost been replaced by tacrolimus. So cyclosporine is not used much nowadays anymore. There are few clinical scenarios where it is used. One is that IV formulation is available, that is there. Then tacrolimus has its own side effects. So if you want to avoid those side effects, then some side effects are better with cyclosporine. So then we use it. Like it is said that if the patient has hepatitis C infection, then C plus TAC causes more NODAT. NODAT means new onset diabetes mellitus, which is one of the complications of renal transplant. One is infection, one is rejection, and another is NODAT. So in those patients who have C, we often combine with cyclosporine. So there are few instances where cyclo is used, but it's only about 10-15%. It's still there in the market. Okay? But TAC is now the backbone of renal transplantation. So I said TAC was introduced in the early 1990s. It was used by the liver people. We started using it much later. It is a superior immunosuppressive. It is more potent in pharmacological terms. You see there the dose is 5 mg per kilo. Here it is only 0.1 mg per kilo per day. This is also given conventionally twice daily. Sometime back, it's almost I think 8-9 years back, a single daily dose regime formulation has also been introduced in the market. I do not think it has become very popular, and I don't think many people are using it. Something very odd happened with tacro. See, with cyclosporine, as I said, Novartis introduced cyclosporine and they introduced it to our country as well, and we have been using it as Neural. It was known as Sandimune. The initial trade name was Sandimune, and now it is Neural. But TAC, the original brand, didn't come to our country for a very long time. Rather, the generics were introduced first. That was very surprising, but generics came much earlier, and the original brand came in only a few years back, and is not very popular either. It's of course much costlier also. The advantage is it has less recidivism. That's one major advantage. Less gingival hyperplasia. I am not sure about hypertension. It is probably the same. It is probably less dyslipidemia. But the bad thing is that it has more diabetes after transplant. In fact, it is almost 15-20% prevalence or incidence, whatever, after renal transplant. It is more neurotoxicity, more tremors, and causes alopecia. Okay, so that causes hirsutism, and this causes alopecia. So it has more neurological complications and diabetes. Coming to nephrotoxicity, it is probably almost the same. Okay, only thing what people do is that if you have nephrotoxicity with one drug, then maybe you can change to the other and just see what happens. Especially when the patient has HUS or the hemolytic uremic syndrome that is tried. You can switch one to the other and see what happens. This also needs good therapeutic drug level monitoring. Here you do only C2 levels. You don't do C0, what I showed you with cyclosporine. And initial levels are 8 to 12 nanograms per ml. And by the 6th month, we come down to 3 to 5 nanograms per ml. The nephrotoxicity does not necessarily correlate with the levels. They give some idea, it should be done, but they do not necessarily correlate very strictly. And the drug interactions are the same as I told you. Now just to show you that how after this gap was introduced, the proportion of patients with NODAT or diabetes increased. And you see it's almost became 20% with tacrolimus. Now coming to another group of drug, that is the sirolimus. Now sirolimus is basically a mammalian target or apomorphism inhibitor. We call it popularly as the mTOR inhibitor. Those are called CNIs, and this is mTOR inhibitor. These are basically required for growth, and so it is also called as a proliferation signal inhibitor, or the PSI. That was CNI, this is PSI. And this also inhibits the lymphocyte proliferation. They act at different target points in the cell cycle. I'm not going to follow the details. It has antifungal and anti-tumor agent. You see, all the previous drugs, cancer was one of the important side effects. Sirolimus, one major advantage is that it doesn't cause cancer. In fact, it is an anti-tumor agent, and also very importantly, it is non-nephrotoxic. So it seems that it's a wonderful drug, isn't it? I mean, it causes no cancer, it is non-nephrotoxic, but then it has its own share of problems. It delays wound healing, it causes lymphocyte, and in the initial studies it was used not immediately after transplant, but about 1 or 2 months after transplant, after the wound had healed. But now there are some recent studies where things have changed. I'll talk about it subsequently. It is good, but then as you can see, it has a host of problems. Like MMF, it also causes bone marrow toxicity, so it can cause leukopenia, anemia, thrombocytopenia. It causes much more dyslipidemia than the steroids. It can cause mouth ulcers. It causes a non-infective type of pneumonitis. It can cause a skin rash. It is not nephrotoxic in the sense CNIs are, but then it is also nephrotoxic in some ways. It delays recovery if the patient has acute tubular necrosis, so especially in cadaver, if put in a cadaver transplant patient is bound to 80 and might delay the recovery. It affects the podocytes, the podocytes filtration barrier in the glomerular basement membrane, and it can cause proteinuria. So one has to monitor proteinuria very carefully. But it causes no hypertension, no neurotoxicity, no gingival hyperplasia, no nephrotoxicity, so there is no IFTA. These PSIs are available as sirolimus, which was the original drug, and everolimus. These are two types of PSIs available. For sirolimus, it will give initial loading dose of 5 mg and then 1 to 2 mg per day as a single daily dose, and you maintain a level of 8 to 20 nanograms per ml. Even they require drug monitoring. Everolimus is a little easier to use. It comes as 0.25 and 0.75 milligram tablets, and you can use these drugs instead of CNIs with prednisolone and MMF, and especially if the patient has some nephrotoxicity, then one can use this drug. But the problem is that the overall rejection rates are more as compared to the CNI regimens. One would have thought that because it causes no nephrotoxicity, the long-term graft survival would be better. But unfortunately, no study has shown that it really improves the long-term graft survival. So where do you use it? As I said, because it has anti-tumor action, it is definitely useful in malignancy. So with the standard regimens, after 10 years, almost 5 to 10% of patients develop malignancy, which is really sad. So if the patient has developed malignancy, then one can switch over to sirolimus. So if the patient has developed post-transplant lymphoproliferative disease, or what we call as PTLD, or type of sarcoma, Kaposi sarcoma, which is a skin malignancy, then one can use it. If the patient has CNI toxicity, then one can think of changing over. One has to be careful. It is not used if the creatinine is more than 3 or the proteinuria is more than 1 gram per day. Or in fact, some say even 800 milligrams per day. So one has to monitor the patient's proteinuria carefully before giving it. It is much costlier than the CNIs. As I said, because the CNIs we have the generics for TAC, the therapy cost is much less. Sirolimus is very costly. And so the usage is about 10 to 15% of all transplants. Okay, so 85% are on the standard CNI based regime. We have some generics now and we can use the generic, but even the generics are very costly, they are not cheap. Now, what are the rules for switching the immunosuppressives? Because as I said, I like to switch from one to another for various reasons. So when you are switching from AZA to MMF or vice versa, you don't have to worry. Okay, it's the same pathway. So you can just in the morning give one formulation, give a different one in the afternoon. Don't worry, there's nothing to be worried of. Cyclosporin to TAC and vice versa is again a simple switch, both are CNIs. So appropriate doses of the respective drug you can give. If you are doing a switch from CNI to sirolimus, for whatever reason, malignancy or something, then because they act at different sites, one has to maintain an overlap of at least 3 to 4 days. You can't just stop one and start another. You give a overlap for 3 to 4 days. You gradually taper the CNI and introduce the sirolimus. Now, having talked about the basic regimens, now we'll talk about the antibodies or the biologicals which are used in transplantation. Now, these antibodies or biologicals are basically high molecular weight. See, all the previous drugs are very small molecular weight, all of which are made in the lab, in factories. But these are antibodies and these are biologicals, and they have to be prepared in a very particular manner. So the first one which came to the market was a polyclonal antibody against the T cells, and it was derived by injecting the rabbit or the horse. So you immunize a rabbit or a horse, and then you take their serum and concentrate the antibodies, and you get the polyclonal antibodies. So they are polyclonal, they are against various antigens, okay, not against one antigen. That's why it's called polyclonal. And you have two types. If it is against the prepared by injecting the rabbit, it is the anti-thymocyte globulin or the ATG, and ADGAM if it is by using a horse. Doses are different. I will not go into much detail. I'll talk about it in a minute. Then you have the monoclonal antibodies against specific receptors on the T or B cells, and they are very specific. So you have the anti-CD3 or the muromanab or the OKT3, which was injecting the mouse. You have the anti-CD25, and this was again two types, the daclizumab, which was completely humanized, and basiliximab, which was chimeric, means it had two components, both human as well as the mouse component. Most of the monoclonals are derived from mouse. Then you have the anti-CD20, which is rituximab, which is now used a lot, not only in renal transplant but also in malignancies and general nephrology also. And you have the anti-CD52, which is the alemtuzumab, right? So these are the various antibodies. There are many more. I will not discuss all of them. Now let us see what the status is of these various drugs. ADGAM is not used much anymore in nephrology, and it is mainly ATG. Okay, so you can concentrate on usage of ATG. It is used in some centers, but mostly not used. So it is mainly ATG. We used anti-CD3 till about, I think, 15 years back. Last 15-20 years, anti-CD3 is not available in the market anywhere in the world anymore. So OKT3, which was drug which was used quite a bit. When I have used it, we don't use anymore. It used to cause a lot of reactions. All these are biologicals, and one problem is that they can cause a lot of reactions when you give them. So OKT3 anyway is no longer marketed. So coming to anti-CD25, we have used both, but about 6-7 years back, daclizumab has gone out of market. I don't know why. Actually, theoretically it looks a much better drug because it is completely humanized, but the company has stopped manufacturing. So daclizumab is no longer available, and it is at least 5 years, not more. So what you have now is basiliximab, which is anti-CD25, and CD25 is also called is the IL-2 receptor, the interleukin 2 receptor. So we also call it in short form as the IL-2R. I've not written it here. So capital I, capital L, hyphen 25, small RA. So IL-R receptor antagonist. Okay. So mesliximab is a chimeric anti-CD25 or anti-interleukin 2 receptor antagonist. Then you have the anti-CD20, which is the rituximab, which I said is used widely. In fact, it was used first not by nephrologists but by the hemat people, okay? Because it is and the CD20 is present on the B cells. These are T. These are all T. The CD20 is on the B, and they used it in malignancies, for lymphomas and other things. So it was initially licensed for lymphomas. And then you have the anti-CD52, which is the alemtuzumab. But this drug never came to India. It is used mainly in UK and US. And what I've heard is, as of now, even there the production is very limited and is only used in specific research institutes, teaching institutes where there are specific projects going on. It is not available freely in the market, even in the West. So alemtuzumab is also not used. So basically we'll be dealing with ATG, mesliximab and anti-CD20. So these are the three which are available in our country. So when do you give these antibodies? They are used mainly for induction therapy. Induction therapy means induce a patient, do the transplant initially. And why you do induce a patient, as I told you earlier, one is to delay introduction of the CNIs, the cadaveric donors, which is called as the sequential therapy. Then to prevent rejection in sensitized recipient. Now, we're not going to the definition of sensitized, but just understand that sensitized recipients are those who have some inbuilt antibodies in their blood before transplant against the upcoming donor. So they are sensitized. So then you take out those antibodies and then be very careful that they don't develop it again. Or if they are developed, then you suppress it. So these are the highly sensitized recipients. Third indication is that if you are planning a steroid-free or a steroid withdrawal regimen. So as I said, steroids have a lot of side effects, and many centers feel that they should not be used at all. So that is steroid-free, or you withdraw it in the first week itself. As you must have learned in pharma that if you withdraw it early, then you're not dependent, and your body starts making the appropriate amount. So if you withdraw in the first 7 days, you're fine. So if you're planning any of these regimens, then induction therapy. Then what has happened is we had a recent guidelines from the international societies where they said no, you must give induction to everyone. Okay, so that is another school of thought, and many centers give to all. Now whether it's right or wrong, I'm not going to that, but then it is at least recommended in the guidelines that you give induction to everyone. We don't give to those who are not sensitized. We have to be living donors, parent to child, so we don't. So what happens at the end of the day, about 50 to 70% of all recipients get these antibodies. So this was about induction, means at the start, and then you stop. And then if a patient develops rejection, and so the standard treatment of rejection is you give steroids, you give high pulse steroids. So and the patient has not responded to the steroids, what we call as a steroid resistant rejection, then you can try these antibodies. Okay, those which ones? Not all of them. It is only the ATG actually which is used. ATG and sometimes the rituximab. Mesliximab is not used for rejection therapy. So don't go with the impression that all of biologicals can be used for anti-rejection. No, It is only the ATG and the rituximab, not basiliximab, not even alemtuzumab. Now I talk briefly about these various drugs. So ATG, or the antithymocyte globulin, is given, it started off with much higher doses, but now what is more or less accepted is that you give a small dose of 1.5 milligram per kilo perioperatively, in total 3 doses. Okay, but it is variable, but this is what is roughly accepted. So total about 4.5 to maybe 5-6 milligrams per kilo total. It has to be given as a slow intravenous infusion. Okay, it is not given by a peripheral line, so you need a central catheter. And because of the cytokine release and the reactions the patient can have, we would very carefully give pre-medications. That OKT3 I told you earlier, that caused even more violent problems. This causes much less. The anti-CD25 or the interleukin-2 receptor antagonist, basiliximab, that is given in a very fixed dose of 20 milligrams on day 0, that is before the transplant, and 20 milligrams on day 4. There is no regular monitoring and there is no controversy in this. It's given while peripheral line, it's a smooth affair, there are no major side effects. But only thing is that its efficacy probably is less than that of ATG. So in the highly sensitized recipients, we give ATG, we don't give basiliximab. So in those patients where they give to all, then mostly they use basiliximab. Now this chart will show you what are the practical differences in utilization of these two drugs. The immediate side effects, the cytokine release, the first dose reaction is with ATG. It is not seen with basiliximab. So as I said, it is a smooth affair. In mild to moderately sensitive recipient, you can use either. As I said, many centers give the antibodies. The mild people also some give ATG. Okay? So ethically or legally there is nothing wrong. You can give ATG to all. If you are using a steroid-free steroid withdrawal protocol, then it has to be ATG. It is not basiliximab. I told you earlier that treatment of rejection is only with ATG. Rejection means the steroid-resistant rejection. It is only ATG. Now, because it is a very strong drug, it suppresses immunity. It increases the chances of infection by viruses. It is mandatory to give prophylaxis against cytomegalovirus when you are giving ATG. So what happens is the cost of therapy goes up a lot. Apart from the cost of therapy of ATG, which is only for 3 doses, you have to give this prophylaxis for 3 to 6, preferably 6 months. So that cost of therapy increases, and that we give by the Val-Gan cycle. Basiliximab, it is not a must, but now most people feel that even with basiliximab, one should give CME prophylaxis. So what is happening now is that even those who are receiving basiliximab is receiving CME prophylaxis. Coming to the long-term side effect, there is a definite increase of PTLD. PTLD, which I showed you earlier, the full form is post-transplant lymphoproliferative disorder, type of malignancy. So there is a definite increase of PTLD with ATG. Probably this is not seen in basiliximab. So it's good to remember these differences in the usage of problems with these two drugs. Coming to rituximab, as I said, it is an anti-CD20 antibody. It is used in 2 scenarios. One is the antibody mediated acute rejection. Now just briefly, acute rejection of the kidney is of two types. One is the classical cellular T-cell mediated rejection. In fact, till about I think 10 years back, one concentrated only on the T-cell mediated rejection. One did not really know about the antibody mediated rejection, but now this has been found to be a very important problem. So if a patient has antibody mediated acute rejection, then one gives rituximab. ATG was for T-cell mediated rejection. The other scenario where you use rituximab is when you are doing ABO incompatible transplants. Now the classical scenario setting was the transplantation was always between ABO compatible groups. Okay, so the recipient always received a ABO compatible graft, and that followed the same rules as blood transfusion, which means that if your O group, if the patient is O, is a universal donor. Okay, O is a universal donor. If you are AB, you are universal recipient. So if you are AB, you are very lucky, you can take a graft from anyone. But if you are O, then you can take a graft only from O. But if you are a donor O, then you can give to anyone. And A to A, B to B. Positive, negative rhesus factor does not matter in transplantation. Okay, so we don't really bother about the rhesus factor. So we are only concerned with the ABO. So we did transplants only amongst ABO compatible pairs. But now in the last 10 years, ABO incompatible transplants, and I have not gone to all those regimes, there are specific regimes for that using the text and other things, where ABO incompatible transplantation can also be done. So if you are doing a ABO incompatible transplant, then rituximab is given before doing the transplant. And there are various protocols. We will not go into the protocols. And when you give rituximab, as I said, because it is against the B cells, so you monitor the CD19 counts. It's easier to monitor CD19 than CD20. So it's anti-CD20, but we monitor the CD19 counts. These drugs, as I said, the last came out in early 2000, but none of these drugs really improved the long-term survival. Cyclosporin and TAC, they made a remarkable improvement in the 1-year survival, but not any change in the long term. So then efforts were on to introduce a drug which will improve the long-term graft survival. So basically we wanted a drug which will increase tolerance. The patient will tolerate or accept the graft, acceptance of the graft. We stop making efforts to reject the graft. And rejection is either, as I said, of two types, either by the T-cell mediated or worse is making the antibodies. And these antibodies, they can act either immediately or slowly over years. So when you lost a graft after 10 years, 15 years, it was because of development of these antibodies. So you wanted a drug which will improve the long-term survival by improving the tolerance. So, and unfortunately, CNIs, which is the backbone, which reduces acute rejection, which improves 1-year survival, in fact reduces tolerance. So that was the irony. So now this drug belatacept, this is a T-cell co-stimulation blocker. It acts against the co-stimulation pathway, the CD28 pathway. And this also inhibits the T-cell proliferation and production of cytokines. Cytokines means the interleukin-2 and the interferon gamma. And studies were done and was shown to be useful in combination with basiliximab, steroids and MMF. You see, it is instead of CNIs, so replacing the CNIs in this regimen. And you use it to prevent rejection. This is also not for treatment of rejection. You see, there are two aspects. One is prevention of rejection and second is treatment of rejection. So this is for prevention of rejection. When it was used initially, it was found that many patients developed this PTLD, post-transplant lymphoproliferative disease. And it was found that if the patient was EBV negative, that means Epstein-Barr virus negative, they were more prone to develop PTLD. So now it is a precondition, it is a must. The patient must be EBV positive. That means he will have some immunity to the, he would have got exposed to the virus sometime back, has developed some immunity, and so he is EBV positive. Only then you are allowed to give the belatacept. And it is available as a lyophilized powder and is given only by infusion. Okay. See carefully the regime. Initially it is 10 mg per kilo on days 1 and 5, and then week 2, 4, 8, 12. Okay. And then I think there are another 16 here. No, from the 16th week you start getting 5 mg per kilo in the 4th month. And then monthly. So you have to give this drug monthly continuously. So the patient has to come to hospital to take the medicine. Okay. So now this was in a way a big disadvantage, that the patient has to visit the hospital every month. But the other big advantage was that this ensured compliance, because one of the reasons of using a graft is because of non-compliance. The patient doesn't take medicine at home. He either too sick and tired, bored, doesn't take, or he cannot afford, because these are costly medicines. So non-compliance is a major issue not only in poor countries like India, but you'll be surprised that even in US, non-compliance is a major cause of graft failure. So this drug belatacept improved compliance, but then you have to come to hospital every month for an injection. And it showed very remarkably that it improved the patient and graft survival. Now the initial studies were for 1 year, 2 years, 3 years. They were all very good, and last year in AIIMS, the 7-year follow-up study was published. So that's pretty long, 7 years, and it showed that long-term survival was very significantly improved. And that happened because the patient didn't develop diabetes, didn't develop cardiovascular complications, because the CNIs and prednisolone, they also improve the cardiovascular risk profile. They get more of CV events. And the graft survival also improved in the patients, but it was not really that statistically significant, but then it was definitely better. So these studies were called as the benefit studies. We have these acronyms in our clinical trials. It was called the benefit studies, and it was told in AIIMS that it is a clear-cut benefit of belatacept, that it improved long-term survival. It is not yet available in India. Even in the West, it has not really picked up that much, in spite of these remarkable results. AIIMS published it, and it is the only drug which has been shown to improve long-term survival. Let's see, maybe gradually it will pick up. So that's why I thought I must add this slide this year, because the study came only last year. So belatacept is an important drug which inhibits the post-stimulation pathway. You can remember that much, the CD28. It replaces the CNIs. So you see the history, how drugs have come and gone. One drug came, it made such a change for the better, and then another drug came and that was replaced. So that's how it has been. So let us see what the future has for us. So far we have seen how to prevent rejection. Now we come to the treatment of acute allograft rejection. This is also very important. So when you suspect rejection, what do? When you suspect rejection, the patient maybe is asymptomatic, he comes for a routine follow-up. All the patients have to come for a strict follow-up. There is a follow-up protocol which is very frequent initially. So initially the patients come twice a week. Then after 2 months they will come once a week. Then after 3 months, little less, once in 15 days. And then after a year, maybe once in a month or once in 2 months. So many of the acute rejections are now picked up in asymptomatic patients. I told you the days when patient presented with a florid acute rejection, when only steroid and ASA was used, that is no longer seen, right? So most of the patients are asymptomatic. Some patients have mild symptoms. So many patients are picked up when they come for a routine follow-up. Some patients have some other symptoms. So what do you do when a patient comes with rejection? The first thing, you preferably do a biopsy, okay? And you send the biopsy, and that will take time. If it's a very good center, it will come in one day, otherwise it may take 3 or 4 days. So the first treatment for acute rejection is what we call as the pulse steroids. So what do we mean by pulse steroids? We give IV methylprednisolone 500 mg for 3 to 5 days. Before giving this pulse steroid, one has to be very careful to rule out 2 things. One is infection. Patient should not be having infection, and a basic ultrasound to rule out obstruction. Okay, so the creatinine can sometimes go up because of mild obstruction to the graft. So it is mandatory to at least do X-ray chest, CBC, and an ultrasound, and then you can say, okay, the patient most likely has an acute rejection. This acute rejection, as I said, can be of 2 types. It could be either cellular or an antibody-mediated rejection. So that answer will come after 3 to 5 days. Okay, you don't know at this point of time. But this IV methylprednisolone is effective against both the categories. Okay, so you can give it, and it will probably help. When in using IV methylprednisolone, it's also good to know what is the conversion ratio, because IV methylprednisolone is about 1.25 times as potent as prednisolone. It is costly, okay? Methylprednisolone is costly. So what you can do is that when we have used, what you can do is you can use, instead of methylprednisolone, you can use dexamethasone, 2 mg per kilo. And dexa is about 6.6 times as potent as prednisolone. So that works out roughly the same. So you can use IV dexa, which is very cheap. So you can use IV methylprednisolone or IV dexa. So you give this for 3 to 5 days. After ruling out infection, obstruction, and general examination to rule out any other of this cause of rise in creatinine. These drugs can cause infection, and very importantly, they can also increase the sugar. Okay, so preferably the patient is admitted, or it can be given on an OPD basis as well. The other treatment, as I told you, is that you can use the polyclonal antibodies, the ATGs. Okay. So you can use the ATG, and here it is given for 7 to 14 days. ATG was used for 3 days for prophylaxis, given 7 to 14 days. There are other regimens. You can use rituximab. I didn't talk much about bortezomib. Bortezomib is a protease inhibitor, and this is mainly used against the antibody-mediated rejection. So I didn't talk about that. Then you have the IV immunoglobulins, which can be used sometimes. May be helpful, not very. See, none of these treatments are proven. Okay, I mean, it's all just by convention. And then one can do plasmapheresis. That means you use a filter to remove the antibodies. Because I said some of the, so if a patient is having antibody-mediated rejection, then you can do plasmapheresis using a plasma filter, okay, which is similar to hemodialysis, but you do plasmapheresis and you can remove plasma which will have the antibodies. So these are the various treatment regimes. If it is T-cell mediated, then as I said, you will use AIIMS and then you will use the polyclonal antibodies. If it is antibody mediated, then after this IV methylpred, we will use Ritux, bortezomib, IV immunoglobulin, plasmapheresis, all of them or some of them in combination as per protocols. None of them are evidence-based. Okay? Right, now having talked in detail about the drugs, we come to the second part of our objective, that is we talk about the prophylaxis. See, you can't only give these drugs, you have to know also what other things to be done. So that's why it's very important to know what all you will give. So you will use 4-trimoxazole, one single strength daily for 6 to 9 months, or even for 12 months now. That is given for PCP prophylaxis, pneumocystis carinii pneumonia prophylaxis. So this is given to all transplant patients. Earlier used to give it for 6 to 9 months. Now we should give it for almost longer. It's useful not only against PCP pneumonia but also prevents bacterial UTIs. It prevents toxoplasma, prevents nocardia. So this is very useful and must be given to all patients. Not all centers, but some centers use a fluconazole 100 mg per day for 1 to 2 months prophylaxis against fungal infection. Not all centers use prophylaxis. And as I said, when you're using ATG or as per guidelines in all patients, you're supposed to use this valganciclovir prophylaxis for 6 months against CMV. The dose limit is 900 milligrams, but that is when the patient is normally in function. A transplant kidney has only half the function, so normally we use only 450 mg per day, once day. Right? So this is about the prophylaxis, which must be used in all patients appropriately. Now, how do you handle pregnancy? Preferably, pregnancy must be planned 2 years post-transplant, and the conditions are that there should be no rejection 6 months prior. Steroid dosing must be down to 10 mg per day. Azathioprine is safe to use. MMF is contraindicated. So the patient has been on MMF, then one has to switch over to AZA. Okay. CNIs are safe, but sirolimus is contraindicated because as I told you, they are PSIs, proliferation signal inhibitors. They inhibit growth. So obviously you can't use it in pregnancy. And many of our patients receive ASARVs. So if the patient is on that, this is contraindicated. So all this planning must start at least 6 months in advance. MMF must be stopped 6 months prior to a planned pregnancy. Vaccines. Now, vaccines post-transplant, you can use all killed vaccines, not a problem. We don't use in the first 6 months post-transplant because the efficacy is reduced, because that time the immunosuppression is at a peak. So we don't want to use, because it will be useless that time. Live vaccines are strictly contraindicated. So your MMR vaccine, chickenpox, zoster, oral typhoid, intranasal influenza, yellow fever, and BCG. These vaccines are all strictly prohibited post-renal transplant. See, our patients will have a host of other medications, apart from the immunosuppressives. So they would be receiving antihypertensives. It's a separate lecture by itself. I'm not going to that, but you can use any of them. If you're using ACE inhibitors and ARVs, one has to be careful that patient is not having renal artery stenosis, because it's a single kidney. And if you use a RAS blocker in a patient who has single renal artery, that can cause a rise in creatinine or even acute renal failure. So one has to be careful while using these two drugs. You can use diuretics. Many of the patients are on some CV medication. Large number of them are diabetics. They'll have calcium supplements as well, because bone disease is an important problem in our patients, starting from pre-transplant, continuing post-transplant because of steroids. So they will be receiving calcium supplements, they will be receiving anti-ulcer medications, and sometimes they have epilepsy drugs. So please remember that phenytoin and carbamazepine reduce CNI levels. Valproate is a relatively safer drug. Please remember that kidney transplant recipients have chronic kidney disease. Even if you've done a successful transplant, your creatinine is 1. Remember, it's a single kidney, and its GFR would be around 50-55. So that is actually CKD stage 3, and the creatinine goes up to 1.5 to it is CKD 3-4. So you have to handle all these patients as if they have CKD. We don't tell them that you have CKD, because that will unnecessarily lower their morale. So the patient has 1 creatinine, 1.2. You don't need to tell them they have CKD, but please remember in the back of your minds that they have chronic kidney disease. They are on immunosuppressives, which themselves may be nephrotoxic. So you must avoid NSAIDs and amyclopycides in these patients. You must remember to adjust the doses according to the calculated GFR, especially for quinolones and piperacillin-tazobactam. As I said earlier, short-term macrolides and azoles are okay with CNIs, not a problem. But ATTs given for long-term, that reduces the CNI levels, and so one has to be very careful. So either you don't give rifampicin at all, so you have alternate regimens with moxifloxacin, or you can appropriately change the dose. Okay, you have to increase the dose because CNIs with rifampicin, if you are using TAC, the dose changes drastically. One cannot predict how much it will change. That's why better not to use it at all. Then there is a drug rifabutin, which is said to be safer. That also reduces the levels, but reduces less. So if at all you want to use rifampicin in the current era, it's better to use rifabutin, which is available in our country. So one can use rifabutin because one has to accept that rifampicin is the best antitubercular drug we have. So one would like to use it. So if one has to use rifampicin, better to use rifabutin. I'll end by just showing you some actual prescriptions and what protocols we follow. So when a patient is admitted for renal transplant, this is the proforma which is there, and as you can see here, we have the name, the age, sex, the date of transplant, and then you start the orders. Coming to the drugs, you see these calcineurin inhibitors. You can use either cyclo or TAC. If you're using TAC, you're starting from day -2. Okay, so this is the 7th, you're starting from evening of the 5th, alright, in a BD dose formulation. Same with cyclosporine if you're using cyclosporine. Cellcept, Spangraph is a generic form of tacrolimus, alright, which is the most commonly used brand in our country of tacrolimus. Similarly, Cellcept is not the generic, is actually the original formulation of metformin. Okay, this is the original. Cellcept by Roche is the original research molecule, Cellcept, and as I said, the standard dosage is 2 grams per day, so that's why 1 gram has been written for BD. You will also use methylprednisolone 500 mg in the night prior and 250 mg in the morning. And we start off with the ceftriaxone prophylaxis, single strength nightly prophylaxis, anytime once a day, day -1 or -2. And then there are other pre-op orders which we are not discussing here. So it's good to know how the proforma is filled and the protocol. Now this is a real prescription, because when you are in OPD clinic, you may not be a transplant physician, but the patient may carry a card, may some other illness has come with the card. So you should understand what has been written, right? So what is written here? He was transplanted on the November 2012. Okay, and he has come the first or maybe second follow-up December 3rd, 2012. You see what all he is getting that time? He is getting Pangraph 3 mg BD, so that would have been adjusted so that his TAC level is around 10. The other problem is the dose and the level, is very difficult to predict. We have the standard doses 0.1 mg per kilo per day, or 0.15, some give 0.15 milligram per kilo per day, 2 doses. That is to start off. But then how a patient will respond, react, is difficult to really judge, and that one has to keep doing the levels very frequently. Abroad they do the levels daily, in fact, as long as the patient is admitted. Even we do quite frequently. We do twice a week. So you see this patient is getting 3 mg BD. This is immediately post-transplant. That's why I took this. And this is a donor as a sister. Right? And he's on a standard TAC twice-1 regime. He is also getting fluconazole, which I told you that even in our own hospital, there are 3-4 surgical transplant, 2 surgical units basically. So one of them uses fluconazole, the other one doesn't. So I mean, it's okay. But you see Ceftriaxone everyone would get. Ceftriaxone SS 1 daily. And in addition the patient is getting amlodipine, an antihypertensive, and it's probably metoprolol, not very clear. Metoprolol 50 mg. And then when he comes, you order these investigations, attack level. CBC is always done in all the patients at every visit. KFT would be done. KFT means urea, creatinine, sodium, potassium. Ideally, sugar should also be done in all patients every time. LFTs are not done every time. Here it is being done. Alright? And a urine would be done. So this is his follow-up visit 15 days post-transplant. And this is how the prescription will be written. And now what we find here that he has come with some epigastric discomfort for 1 day. You see the person has not written the date here. So that's why I am very particular about one thing, that whenever you fill a card, please write the date and the patient is very sick, the time. Otherwise, it becomes difficult to understand and the whole thing becomes meaningless. But obviously this is on a different date. So you see this handwriting and this handwriting is different. So patient has come subsequently sometime and referred to emergency for urgent ECG because of epigastric discomfort, and heart rate was low, 56. Okay, so we nephrologists have a very tunnel vision sometimes. So low heart rate means we think that patient may be having hyperkalemia. You see, this is a transplant patient, probably he has normal functions, so I don't think he would have had hyperkalemia, but instinctively calcium gluconate has been prescribed for treating hyperkalemia. So he referred to emergency, calcium gluconate was given. And then the same day or next day, I don't know, they discovered that the patient had chicken pox, so varicella. So the epigastric discomfort, pain and all these things is probably because of chicken pox. So this is one of the complications of transplant. And then the dose of valganciclovir has been increased. Patient was getting prophylaxis. No, patient was not getting prophylaxis. You see, there is no prophylaxis against CMV. CMV covers the other viruses also. And so then valganciclovir was introduced, right? And what you have to do along with valganciclovir in chickenpox is you have to cut down the cell set or even stop it. So, and metoprolol was stopped because it was thought that it is contributing to the low pulse rate. This is how you work in the clinical scenario. And then if you go back to the prescription and the treatment, you see diagnosis, you see here someone added subsequently post transplant varicella zoster. Okay, so that's how you keep writing the diagnosis. So diagnosis in a card will include, I don't like PRT because people will not understand what is PRT, that only nephrologists understand. So it's simple to write renal transplant, it doesn't take very long. And you don't have to write DOT also, just write the date, that means he has been transplanted that day. Donor was a sister, best serum creatinine was 1, he was on a standard triple drug immunosuppression, which we talked about in detail, TAC, Vislo and MMF, and the patient developed shortly after transplantation post transplant varicella zoster, okay, which was treated with oral valganciclovir. Right. So now let's go to another prescription. Now this prescription is of a 30-year-old male who was transplanted on 19th of February 2007, donor being the brother, and this card is 6 years post transplant. Just to show you, how what the patient is getting. Now at this point of time, see the patient is getting Pangraph 2 mg and 1 mg. Prednisolone is still getting 7.5. Ideally, it should have been brought down to 5, but anyway, some patients remain on 7.5. Azoran is getting 100 mg. So he's on Azoran based regime, not cyclosporine or TAC. So as I said, it's 2 mg per kilo, right? So most of our patients are about 50 kilos of Azoran. He's getting, this is Arcamin, 0.1 mg BD. Arcamin is clonidine. He's also getting Shelcal and he's getting pantoprazole. So this is a prescription, and this probably for 2 months, and this would be just written CT all, because this would be roughly his baseline prescription for months and years to come, right? Okay, so now let's see another prescription. Now this prescription is not that clear. It's also probably of a long-term patient, and just to show you that the patient is getting a Vicelone 5, you see Celcept is only 500 BD. Yeah, I want to show this. So with TAC, you can really cut down the dose of Celcept 500 BD, and this is a very small dose of panagraph, 1 and 0.5. In fact, now because of our Indian circumstances, scenarios, we may have 0.25 mg of tacrolimus available. So we can really titrate the dose very carefully. So some patients even get a dose of just 0.25 mg BD. So you see the immunosuppression in several years. The date again is not clear. One must write dates very clearly, but this is obviously definitely after more than 6 months to 1 year. So very small dose of prednisolone, small dose of MMF. As I said, Celcept is the original research formulation of Roche. Panagraph is a generic form of tacrolimus, a very small dose of 1 and 0.5. Getting an antihypertensive Arcamin 0.1 TDS, getting Ranta, and follow in 2 months. And then patient has come after a long time, so TAC level has been asked for. So TAC level is not routinely done after 3 years, but then the patient comes once in a while, we get a TAC level done. Because we don't play around with the TAC dose after 2 to 3 years, maintain it at the same dose. Thank you very much. I think I've covered most of the things related to immunosuppression with the clinical background. Unfortunately, we can't have an interaction because I don't think the system allows that. So what you can do is you can email me your difficulties. I'm sorry I've not made a slide. I didn't know it was like this, that there's no interaction. So please write down my email. I will just dictate it to you very slowly. So it is D for Delhi, all are small. So D Delhi, M Mumbai, D M, B for Bangalore, D M B, H for Hyderabad, O Orissa, W Warangal, M Mumbai, I India, K Karnataka. So D M B H O W M I K at gmail.com. So if you have any queries, difficulties, please feel free to send an email with your name and any other, which I suppose it's 5th semester, so name and semester, and I will get back to you. Thank you very much.
आधा घंटा बैठे 1 घंटा बैठे कुछ पता ही नहीं। क्लासेस मोटिवेटेड सर कहाँ से केसेस इज गुड सर practical जी, no, when the body is happening at the end of the day,